Okay, so we're now recording the webinar, and this is what you will get a link to at the end. So I'd like to welcome you all to this joint NHS England and ARMA webinar on sport, exercise and musculoskeletal training and delivery in the NHS, which is going to be presented by Dr Natasha Jones and Dr Mike Rossiter. But first of all, we'd just like to get an idea of who we have on this webinar so that we know who you are. So I'm just going to launch a poll, which those of you who are able to take part in the interactive parts should be able to say whether you are a commissioner, a GP, consultant, manager, allied health professional or other. And I can see lots of people voting here. So we've got lots of AHPs, lots of others, GPs. We've got someone from all of those. So I'll just give you another second or two to vote in this, and then I will post the poll so that everyone can see the results. So I'm just going to end polling now and share the results. So most people are in the other category, with AHPs a close second. And then we do also have commissioners, GPs, consultants and managers online, which is great. So I'm just going to stop sharing the results and invite Natasha to start your presentation.
Thanks very much, Sue. Thanks. So I'm Natasha Jones. I'm a consultant in sport and exercise medicine, practicing in Oxford. And I'm also the Vice President of the Faculty of Sport and Exercise Medicine. And I'm sharing this webinar with my colleague, Mike Rossiter, who is a consultant in sport and exercise medicine in Hampshire. And he's also a member of the Faculty Council. So now, why won't my slides go? Sorry about this. Right, there we go. So the webinar this afternoon will be mainly about musculoskeletal medicine, but I'm going to do a run through of the Faculty of Sport and Exercise Medicine and the specialty, the scope of work of our consultants. I'm going to touch briefly on exercise medicine and the sort of importance of it and the current work streams that we're involved in. As I said, the main focus of this will be about MSK service delivery through SEM, and Mike is going to present his service as an exemplar with some supporting data. And then at the end, we'll talk briefly about training, accreditation and research. The first thing I really want to do is dispel the myth that sport and exercise medicine consultants are mainly involved in elite sport, because although some of us do some elite sport as part of our portfolio of work, the vast majority of our work, as you'll see from this presentation, is in the delivery of musculoskeletal medicine in the NHS, the military and beyond. But I don't really want to discard the title sport too readily, because I believe that it's our background in sport and our passion for human performance, for the principles of rehabilitation, for teamwork that really gives us an edge when it comes to delivering musculoskeletal medicine for everybody in the NHS. Right, so the faculty is an intercollegiate faculty of the Royal College of Physicians and the Royal College of Surgeons of Edinburgh. We're now over 10 years old, launched in 2006 on the back of the sort of energy and positivity that was created when we won the London 2012 bid back in 2005. And it's a testament, I think, to our adaptability and our ability to deliver musculoskeletal medicine at a reduced cost and with high quality, that we've been able to grow over the last 10 years of austerity. We now have 600 members and fellows of our faculty and over 120 consultants working across the UK. So to be a member of our organisation, you need to have passed our membership examination, which tests knowledge, skills and professional attitudes and the competence of a doctor wishing to practice musculoskeletal medicine. To be a fellow of our faculty, you need to complete our training scheme, which I'll go into in a little bit more detail at the end of this. And very briefly, the responsibilities of our faculty are similar to any other faculty in that we are responsible for governance of the specialty, for standard setting, for the professional code of our specialty, for examination, accreditation, revalidation and appraisal, and for accrediting some of the skills that we use on a daily basis, like ultrasound skills. We obviously engage with government, other colleges, and national and international organisations on behalf of the specialty. And we're very focused on promoting the importance of exercise medicine and the delivery of exercise medicine in the NHS as well. So just touching briefly on exercise medicine, we all know that physical inactivity is universally accepted as a biggest public health problem of the 21st century. And it's on that background that we see these sorts of headlines, which these have been just in the last couple of weeks, really. A big headline in The Guardian that GPs in England feel underconfident generally discussing physical activity with their patients. That's a concern when we're talking about the biggest public health problem of the 21st century. And then I'm sure you've all seen this Telegraph headline that 4 in 10 adults fail to manage even one brisk 10-minute walk a month. And those of us who work in the NHS know that that is almost certainly the case. So a little quiz here. I just want to understand how much you all know. I can see there's lots of AHPs, probably physiotherapists in the audience, so I'm sure everyone will do very well in this, but if we just answer this. Children aged 5 to 18 should be active for at least how many minutes a day? How are we doing, Sue? Is everybody had a
yeah, there's lots of voting going on. There's
wonderful.
One fairly clear favourite. I think we've finished the polling now, so I'm going to close the polling and share the results.
Well, that's very good. 50% of you got that right, which is excellent to see. As we know, the guidelines, government guidelines for adults are 30 minutes a day. For children, that goes up to 6 minutes a day. So you obviously a very well-educated audience, but we'll just go on to the next slide. Hang on, it's not going again, Sue. I
wonder if I
think it might be something you're doing at your end, actually. I'm just gonna
close the polling while you're trying to sort that out. Can I just say we're getting quite a few questions through on the question board. Quite a lot of them are actually not directly relevant to the topic in conversation now, so we will be able to respond to questions afterwards by text, but we will try and refer those that are not relevant to today's topic to someone who is relevant. How are we doing at your end, Natasha?
Okay, I'm there. Can you see me?
I can see you.
Can you see my slides?
No.
Okay, let me just
try sharing your screen again.
Okay, here we go. Right.
Yep. That's what, yes.
Okay. Oh. Okay. So which gives you the best chance of being alive in 12 months if you have symptomatic ischemic heart disease?
So again, I'm launching the polling. And the results coming in. Not quite, but very nearly unanimous. A few people still voting. I think we've now finished that. So I'm going to end the polling and share the results. Lovely. So fairly obvious answer. But again, yes, every time we do a poll, I struggle to move on, actually. Okay, so I'm going to stop sharing and close the polls. Okay. Sorry about this, everybody. It's very boring.
Yeah.
Okay, there we are.
Okay.
So, yeah, the figures are quite stark there. The difference between exercise and percutaneous coronary interventions, and also significantly how much cheaper exercise rehabilitation, and this is a formal rehabilitation service compared to invasive procedures. So exercise medicine, really important as we know. The WHO are about to launch their global action plan on physical activity, which is a very wide-ranging document focusing on the big societal things like green spaces, active transport, and so on. But really importantly in that document, there's a role for health professionals, and in particular for specialties like SEM in the education of health professionals, optimising healthcare pathways, leading exercise rehabilitation services, so they're really fit for the future for multi-morbid ageing populations. And then really importantly, for the evaluation of those services and research of new services. And of course, we've been doing this for quite some time, really, in a sort of pilot local way. This is one that's been done in Oxford as part of a sort of Age UK community project. This is a health professional education resource, which you can have a look at if you like, and it's been really well received. And off the back of all of those sorts of interventions, Public Health England, I'm pleased to say, in combination with Sport England, have launched their Moving Professionals Forward model, which really focuses on educating health professionals, particularly doctors, from an undergraduate level right the way through to their continual professional development and the end of their careers. And there's many work streams in that phase of work, which is just beginning now. The areas that particularly we're involved in as a specialty are in developing clinical care resources for physical activity for chronic disease, and in piloting a sort of secondary care model of a consultant working with the sort of very tip of the iceberg patients who aren't really catered for in current rehabilitation services, but we know can really benefit from exercise interventions. And these are an example of some of the work that's already come out. There's an infographic there, physical activity for pregnant women, and we'll be developing those infographics across chronic disease over the next year. And then there's the children's one, which you obviously already know a fair amount about. And you can download these resources from the Department of Public Health website. But anyway, coming back to the most important part of this presentation, which is about musculoskeletal medicine, SEM consultants following formal medical training and then higher specialist training work in teams, and I think it's that part which is really important to provide comprehensive care. We obviously have the ability to diagnose and treat complex MSK presentations, to recognise inflammatory presentations, and only refer appropriately for surgery, and that's why we can save money. We do deliver through a range of models, the sort of typical secondary care model for complex MSK cases, the one-stop shop MSK clinics, often in communities, which offer on-the-day investigation, diagnosis and treatment, and then MSK triage services, which, as you know, is an NHS England directive now. We can offer high quality clinical triage with an aim of getting it right first time. And this is a recent poll we did of our fellows. And as you can see, this is where they said they worked. This is in the last year. So our fellows are practicing really widely across the UK and the 4 nations, and in the military, and then in the institutes as well. If you want to know more about the sort of service models that we offer, do download this document, A Fresh Approach in Practice, which you can find on our website. But over to you, Mike.
So before Mike starts, we've had a question here from someone saying, I'm an exercise specialist and I want to know if I can train in SEM if I'm not clinical but have lots of MSK and injury rehab knowledge. So you'd like to answer that. But.
So our specialty is especially for medical professionals, for doctors. There are, however, formal training schemes for exercise professionals, which if you email me afterwards, I can share with you. Right, Mike, you're on.
Okay. Can you see my slides? Okay.
Yes,
Yeah.
they're looking fine.
Well, thank you very much, Natasha. As you may not have realised, that Natasha and I are both webinar virgins, so forgive me if I'm not quite as slick as Natasha, who has given a very sort of concise summary of where we are at the moment. But what I'd like to do is lead on and really demonstrate what I think, and I admit I'm slightly biased having set up the service, I think is a good example of an MSK triage and delivery service that we run within the Basingstoke and North Hampshire area. I've been working in the Trust since 2003 under a variety of guises, and really for 10 years banged my head against a brick wall trying to set up a bespoke service. And eventually, in 2015, managed to set up what we now currently run, having been given the opportunity to run a year's audit of showing that the service could work. So what I thought I'd do is guide you through very quickly what the audit showed, and then what we currently use as a service that's running at present. So the aims really were to centre around the patient experience and also to minimise and simplify investigations and to try and aim for more non-operative management. We know that a variety of MSK conditions don't need surgery, but traditionally they've always ended up under the orthopaedic department, who either don't have the non-surgical knowledge that Natasha's presented that we do possess, or they're more likely to get surgical procedures that are frankly sometimes unnecessary or perhaps too early. And so the aim is to try and improve the patient experience so that they get seen as little as possible, seen close to home, and they get sorted appropriately. So the audit ran for a year and involved myself as a sports medicine consultant and one senior ESP and extended scope practitioner. And we took all the referrals referred to the orthopaedic department from the Andover area, so a population of about 50,000 patients, and we triaged every week to go to one of three areas: to either come to an MSK clinic run by myself and the ESP, to go to physiotherapy, or to go to trauma and orthopedics. The physiotherapy referrals were ones that obviously from the referral it was felt that they would benefit from at least an initial trial of physiotherapy, or that really physiotherapy was suitable for them, or the patient and or the GP had specifically requested physiotherapy. And the ones that went straight through to orthopedics were the ones that obviously needed an orthopedic opinion, which was outside the scope of a non-surgeon. So, for instance, somebody who clearly needed a hip or a knee replacement, or had complex surgical conditions that couldn't be managed in a non-surgical environment. And again, if a GP and or the patient had specifically requested that they wanted to see a surgeon, we felt it was very necessary and appropriate that they should be allowed to see the person they wanted. So we ran the trial from October 2013 until August 14, so just under a year. We saw a total of 613 patients, and you can see from the results that the majority in this trial actually ended up in the MSK clinic, and actually very few went to physiotherapy, only 1%. And that's possibly because or probably because the GPs in the area were very clear as to who they wanted to go to physiotherapy and would refer directly to physiotherapy. But you could see that only 14% of patients were felt that they needed an instant surgical referral. In order to streamline the patient experience, if it was felt that the patient needed to be investigated before they came to clinic, then they were organised, the relevant investigation was organised before they attended. But you can see that the results are very low. So only 2% we felt needed an MRI scan, and that would be for conditions like somebody had got a clear diagnosis of a meniscal tear or a ruptured ACL in the knee. Only 2% had x-rays pre-ordered. That's possibly low because a lot of the GPs had already ordered the x-rays, although you'll see later on that actually in the MSK clinics, our x-ray rates are a lot lower than orthopaedic clinics. And very few needed ultrasounds. I think that translates to about 1 patient. But when we actually investigated them in clinic, I am trained in ultrasound, and I ultrasound in clinic to help with diagnosis and also for ultrasound guided injections and aspirations. And a quarter of patients actually ended up having this. 3% we x-rayed on the day because we felt it was necessary to do that. And 16% ended up having had a history and examination and MRI scan. And
just before you go on, Mike, we've had a question here. How does the MSK clinic differ from physio?
That's a very good question. So physiotherapy, we felt the patients referred to physiotherapy was for specific physiotherapy intervention. So soft tissue therapy, manipulation, not just a diagnostic and treat. So ours was mainly for to prove diagnosis, to investigate appropriately, and if something was interventional, then we would be able to do it in clinic where we felt the physio department was unable to do that. Does that help, Sue?
Does that help, Matt? If you put your hand up, if it does. Not sure.
Okay.
But I think so, yes.
Okay.
Oh, yes,
okay.
Matt says brilliant.
Okay, thank you. Thank you, Matt. So you can see from the trial that the vast majority were discharged. So 39% were discharged and 27% were referred on to physiotherapy for ongoing treatment, which, to answer Matt's question, were those that we felt didn't need any particular intervention, certainly not surgery, but would benefit from physiotherapy. So we clarified it within that clinic appointment. 9% were directly listed for surgery at Basingstoke Hospital. Now, the reason we were able to direct list them is that I've been working in the orthopaedic department for several years. I had a very good relationship with the surgeons, and they were happy for me to directly list certain conditions. For instance, carpal tunnel decompressions, trigger finger releases, shoulder decompressions, knee replacements, hip replacements, because they were happy that I had properly worked them up and counselled the patient. 9% were referred to Basingstoke Hospital for a trauma and orthopaedic opinion, and 7% went to Winchester for an opinion, having not had exactly the same relationship with the Winchester surgeons. I couldn't initially directly list, but by the end of the trial, 3 of the surgeons out of the 8 were very happy for me to directly list, thus saving the patient another appointment and another wait. 5% went on to have either further investigation or treatment, such as EMGs or a platelet-rich plasma injection or a hydrodilatation for a frozen shoulder, and 4% ended up going to podiatry. Sorry, there we go. So the key points was that when we actually set up, following that audit, we actually set up the proper service, which now runs currently at Basingstoke Hospital and Alton Community Hospital, was that it was felt that those were the best central locations to access our patient population. There's been, having attended a lot of meetings fairly recently, there's been some criticism that the MSK service is hospital run and hospital based. Just to clarify, it is in those hospitals because it's felt to be the most central location and it's easily accessible to radiology and pathology. That's not to say that I feel it has to be run in a hospital setting, if that makes sense. We also felt, you can see from the previous audit, that we didn't separate spinal and non-spinal, but we felt, having looked at the service in more detail, that spinal services demand different, have a different patient demand, so they're more complex, there are more avenues to go down, and so we split our spinal service and non-spinal service into two separate parts, but they are jointly run, if that makes sense. Forgive the alarm, don't panic, I'm not about to burn, if you can hear it. The administration currently is run by Virgin Care. The reason for that is that Virgin Care used to run the previous service, and without getting too complicated, it was agreed that they would run the current service. Now, I'll go on to why there are good points and bad points to that. The hospital bid for, the trust bid for and won the podiatry, the MSK part of the service and spinal service. The podiatry and physiotherapist service was split and continues to be run by Virgin Healthcare, which again I'll come back to. Currently we are paid by patient referral, not outcomes. So it's up to us to make sure that we see our patients as quickly as possible and move them on, because it's actually no financial benefit to us seeing them 5 or 10 times. We get paid per referral. So how does the service run? The service now runs on an electronic choose and book template. So it's a paperless system, and under the terms of the contract when we set it up, we actually use a system called EMIS Web, which is a primary care system used by all the GPs in the locality. And the idea behind that was to so that we can data share for rapid communication, and so people can actually, GPs can actually find out what's happened to their patients on the day. We set this up 3 years ago. We haven't actually got to the point of data sharing. We are soon to do that, but as I'm sure most of you know, the wheels of the NHS and CCGs turn incredibly slowly, but that is the idea behind it. We triage daily, 5 days a week, for MSK and spinal. The triage is done by either myself as the sports medicine musculoskeletal consultant, or 3 other senior ESPs. The MSK clinic, we see them once and we either follow them up by telephone, which is the vast majority, or clinic, and we have a monthly performance meeting with our local CCG so that we get feedback either way as to how it's running. I feel very strongly that there is an educational element to this, because obviously the better GPs and physios are at diagnosing and treating conditions, the less referrals will actually have to come into the MSK service at all. So we have a weekly educational seminar, and we regularly have GPs, physiotherapists, podiatrists sitting in on clinic with us. And as from August, we've managed to get the services of our first GP specialist trainee, who is here for 6 months to learn all about MSK, so that she then goes into her general practice a better trained person. So what are the key points of how we run it? The MSK clinic currently has myself as the consultant. We're just about to appoint another. 3 GPSIs, so general practice GPs with specialist interests, and 3 ESPs. And the spinal service has 1 spinal surgeon and 4 ESPs. What I think makes the service particularly good is that it's, and again, one of the reasons why we run it within the hospital is it's integrated with the orthopaedic department, and we run the service alongside the daily fracture and elective clinics on the day. And I feel that that works particularly well because we can then talk to, and they can talk to us, the surgeons can talk to us about patient care, about investigations, about ongoing management, and again, without having to write letters, wait for a period of time, and often the patient is dealt with on the day by either the MSK specialists or the surgeons, and a management plan is made on the day. We've also managed to set up a shockwave clinic for treating tendinopathies, which is working unbelievably well. It seems to be a multi-headed monster now, it's so popular. And we do a lot of things in-house, again, to try and streamline. We do our own ultrasound scanning the majority of the time, ultrasound guided injections. We even do our own EMGs in clinic. So if you look at our numbers,
quickly got a question here coming in saying, what's the average waiting time for an appointment? So how long
right, that is, you'll see on this slide, that answers the question.
Yeah, jolly good.
So we have 700 referrals a month currently. This is for just the MSK side of it. This is not the spinal side, which I'll come on to. And 90% are deemed to be routine, and they wait an average of 6 weeks, which is considerably better than its predecessor. And 10% of urgent cases, and they wait no more than 2 weeks. We triage on average 35 to 40 patients a day. And you can see that the majority still come to the MSK clinic. We feel that 5% are not actually MSK and have been referred to, if you like, the wrong service and are transferred without having to go back through the GP to the spinal service. And 30% are felt to go straight to physiotherapy. I'm sure the question will be asked is how many go from physiotherapy back to MSK? And that's recently been audited, and it's less than 10% of those 30%. So on average, we seem to get the triage right. 7% go to podiatry, 5% are rejected, and they're mainly rejected because of the GP putting no detail on there. So they just tick that they want a shoulder to be seen, but without any detail, or they use the service inappropriately. So for instance, please may you see this person with corns. That's not a service we offer. That's not what the podiatrists are there for. You'll see that only 3% of our referrals goes directly through to orthopaedics and 1% to rheumatology. So a very low number indeed. So actually, in clinic,
there's another question here about those who need physio. How long do they have to wait once you've referred them? Do you know that? Yeah,
good question. The average wait for a routine physio is 4 to 6 weeks, and an average wait for an urgent physio is 2 weeks. And again, compared to its predecessor, the average wait for physiotherapy was around 3 months, and when it started, it was 6 to 12 months. So we've brought that right down. Happy to carry on?
Yep, thank you.
Yep. So when we look at our numbers, we see roughly 50% of new patients and 50% of follow-ups, of which the vast majority are followed up on the phone. So those are patients who've had an intervention and we want to see how we want to know how they've got on, or they've had an investigation and we feel that we can talk to that patient on the phone and deal with them on the phone rather than them having to come in. Most patients have reported that they much prefer to be telephoned so they don't have to pay parking charges, they don't have to wait, and most of them are available on a mobile phone. Similar to other services, we have between a 7 and 10% DNA rate, which is disappointing, but the majority of those are phone calls, people being unable to answer their phone, or unfortunately, a lot of people won't answer a phone that has no number, a name attached to it, but for reasons of confidentiality, we can't put that we are the service phoning them. When we review patients, as you can see, the majority are telephoned, and we discharge 46% of patients from clinic and 59% of patients from the telephone clinics. We do about 15% of procedures, and we only refer on 12% to secondary care. 65% of those go to trauma and orthopaedics, and 28% go on to either a spinal service, a pain service, shockwave clinics, or rheumatology. And out of the 65% that get through to trauma and orthopaedics, they are for patients that we either feel need a specialist orthopaedic opinion, and hopefully we're able to actually do that on the day, or they need surgery or a surgical intervention. And again, a recent audit, 85% of our patients we referred through to surgery have surgery. So again, we feel that we're getting it right, that we're getting the patients through to surgery that need a surgical intervention. Diagnostics is always a major issue with NHS finance, and we only do diagnostics on 27% of our patients. And you can see that MRI only forms 2% of that, and X-ray 3%. Now again, the X-ray is low because a lot of GPs will X-ray beforehand under guidelines that we've given them. And actually in clinic, our MRI rate is only 15%, and X-ray rate only 5%. And if you compare that to a normal orthopedic clinic, MRI rate is around 40 to 50%, and X-rays are around 70 to 80%. We refer only 1% to radiology, and we do our own EMGs in clinic. So our finance layout for investigations is very low compared to a hospital orthopedic service. So moving briefly on to spinal, the spinal service, as I say, runs slightly differently because of the different needs of they're often more complex patients with complex needs. And we currently receive about 300 referrals a month. 90% are seen within 6 weeks and 10% within 2 weeks. Now, comparing that to other services, that is hugely different. So before our spinal service set up, actually using the south part of our trust, the Winchester part of our trust that doesn't use our service, as a comparison, patients are waiting 6 to 12 months often to see a spinal surgeon because there is no other service, and we can see them within 6 weeks. Triage patients about 25 a day, so slightly less than the MSK service, and you can see that the vast majority are not seen by a surgeon. So 83% go to physiotherapy, specialist spinal physiotherapy, and 26% are seen by the specialist physiotherapists in our service, with only 1% having to see a spinal surgeon. And of those 1%, less than half of those will actually have surgery or an intervention. So it's massively cut down the interventions that we have to do for the spine. So you can see the outcomes. Only 4% have actually ended up having an epidural, and less than 1% have surgery, which is hugely different to spinal services elsewhere, with 95% either being discharged, going to physio, or being sent to a pain clinic. The big difference is the investigations, and this is where it becomes controversial. So the overall investigation rate is 37% of our patients are investigated. But of those that are investigated, 94% will have an MRI scan. Now that looks huge and is the most costly part of our service. But it was felt by our spinal surgeons, and this is based on international data, that actually if you give a patient an MRI scan who you're going to see in clinic, it saves, in the long term, a lot of money and a lot of time, because you can point out to the patient that there is or isn't a problem there and how it can be managed. And a lot of patients expect to have an MRI scan, and you can therefore sift them out very quickly as to who actually needs a surgical intervention and who doesn't. Now, again, you can argue this either way, but it's felt very strongly that that patients should have this before attending clinic, and by and large it works very well, but it is costly. So overall, what do we think are the advantages of this service? Again, I'll hold my hand up and be very biased that I am a doctor, although some would argue that. We feel that a doctor-led service works better than a physio-run service. Now, that is not in any way to downgrade physiotherapists or demean them. I actually feel that a multidisciplinary service works better than anything else, where you have a mixture of skills. In my view, doctor-led services tend to be, doctors understand other doctors and surgeons, and they also seem to be better at risk management than a lot, but not all, of physiotherapists. And I willingly expect to be shot down by that. Triage works well when it's done by an experienced clinician. So you need somebody with who knows and understands conditions and can best select where people should go. For me, it is essential that it is integrated with the local trauma and orthopaedic department, that you need to build up a good relationship with them. They trust you, you trust them, and you're seeing the right people. The more in-house investigations that can be done, the better. Because again, that saves time for the patient predominantly, and is also cost saving. Again, personally here, we feel that the MSK and spinal services should run differently. There is a lot of pressure on us to have a single point of access rather than two separate services, and I think that's entirely reasonable, but to mix them together, I think is difficult to makes clinics run differently and longer and not necessarily better. EMIS Web, or a shared system with primary care, I'm sure is the way forward. If you ask me in 6 months, I'm sure it will be the way forward once we actually finally data share. And of course, we should be aiming for a paperless system. As I say, we regularly encourage feedback from primary and secondary care. And overall, it's very encouraging from both sectors. And we have very, very few complaints, patient complaints, which is also encouraging. But of course, I wouldn't for a moment expect the service to be all singing, dancing without any problems. And there are various things that could be improved. So EMIS Web I've already talked about, be it EMIS Web or any other integrated system. Through the nuances of how the system was set up, Virgin Healthcare currently run our administration system, and without insulting Virgin Healthcare, it is just difficult for a service running in one place to be managed by another service. And I personally like it all be integrated into one area. And again, physiotherapy being within the hospital setting or without having to go to somewhere else run by a separate company is also proving difficult, but it's not disastrous by any stretch. So thank you very much. That is the lovely Basingstoke if you ever want to come and visit. I'm sure most people would avoid it at all costs. Any questions before we move on?
So we've got quite a few questions come in. There's some quite. Let's start with the really factual ones, such as: have you got data on patients' age group? What is the percentage more than over 40?
Thank you. In the MSK service, we currently only see patients over the age of 16. We do see younger patients if they have particular needs or they need to, there is specialists within our service that could see those patients, but the majority are over the age of 16. The demographics, most of our patients range between 25 and I would say about 60, but we see patients well over that as well. But those are the patients, the much older patients, the sort of 75 plus, tend to be for degenerative conditions, And those are the ones that we tend to be more in contact with the orthopaedic surgeons, because those are the ones that perhaps should be going on and having surgical interventions.
Okay, and then we've got, what is the re-referral rate back into ED, MSK or orthopaedics within a 12-month period?
Again, a very good question to one I can't give an accurate answer. We haven't audited that yet. We know that there are a number of patients that are referred back to MSK. They tend to be referred back with different problems. So at the moment, we're trying to tease out ones that are referred back for the same problem. And those that go from MSK and then referred back into orthopaedics, again, I can't give you an accurate number, but I do know it is low. I would say probably out of all the people we've discharged, it's less than 5%. And that is, but looking at just a month's worth of referrals into orthopaedics.
Okay, and do you know the percentage of conditions seen that are acute versus chronic pathologies?
Well, it depends what you mean by acute, actually. So it's when you draw the cut-off line between acute and chronic. So the vast majority of things we see are chronic, and I would regard chronic as over 3 months old. Now, that's partly because of the time that it takes for the patient to see a GP and GP to refer up and for us to see. So if you think about it just on a purely practical level, if a GP sees somebody who's had a problem for 2 or 3 weeks and we see them after 6 weeks, you're already into two months plus by that stage. We do see very acute things within, that have happened within a week, but that's normally that the GP has marked it urgent and that we see certainly within a week or two, and that might be things like a suspected ruptured Achilles tendon or an acute soft tissue injury. With knee injuries, with things like soft tissue ligament injuries, in the hospital we have a soft tissue acute knee clinic. So at the moment it's not that people get more referred there than they do into the MSK service. So I think that the short answer is we see probably more chronic conditions than acute conditions.
Okay. And I think, do you have more slides?
No. I've got a couple more, yes.
Natasha has, but I can move them on from here.
Okay, so maybe there's still quite a few questions coming in. Natasha, maybe because we're coming towards the end of our time, if you do your slides, we'll then take as many questions as we have time for, but we will be able to follow up those questions. Those questioners who've put their name in their question, we will be able to answer you afterwards if we don't manage to get to you.
Thanks, Sue. I really thank you so much, Mike, for that overview of your service. And this really is an exemplar and an example of many different services across the country that work in a very similar way. I think the real key to take from all of these services is the team involved, and that does rely heavily on extended scope physiotherapists and more junior physiotherapists, but also on that relationship between the SEM consultant and the other secondary care consultants, so orthopaedic surgeons, rheumatologists, and so on. It's that cohesiveness which makes it such a powerful and successful model. I just wanted to go through a little bit more about accreditation for MSK medicine for doctors, because as you know, it's a little bit of a mishmash out there. Despite 10% of musculoskeletal conditions being seen in general, well, 10% of GP consultations are musculoskeletal conditions. The actual training for musculoskeletal medicine is really poor, even up to GP level. And there's very little focus on this. So we obviously have our membership examination, which gives you a baseline if you're a commissioner in terms of musculoskeletal accreditation. We're really excited to be developing our MSK diploma, which will sit at a sort of diploma level for primary care. And this will really be for GPs to manage conditions in their own practice, to just try and give them a little bit of confidence in their own eyes, but also in the eyes of patients. And we're working hard to develop that in collaboration with the Primary Care Rheumatology Society. We obviously have our association, BASM, who we work very closely with and in partnership with to make sure that their education events fit nicely with our examination and so on. We accredit ultrasound training, which is again really important as more and more clinicians are delivering ultrasound as part of their routine clinical practice. We've currently got 35 more doctors in training to add to the 120 consultants that are already out there, and our training numbers haven't been cut, which considering the climate at the moment is quite an achievement, and it was something we're really proud of and pleased about. Our training scheme follows MRCGP, MRCP or MRCEM, the emergency medicine specialist examinations, and is a 3-year training scheme which focuses heavily on musculoskeletal medicine, with rheumatology training, orthopaedic training, rehabilitation medicine training, and exercise medicine training, as well as some public health. So we do believe our consultants have a very broad knowledge and a very deep knowledge of musculoskeletal medicine by the time they finish. I can't finish this without talking about the importance of research in musculoskeletal medicine. This is something which we're heavily involved with through the National Centre for Sport and Exercise Medicine, which is sort of across the country, and other organisations like the AR UK Centre. And that's the end of my talk. Thank you very much for listening. I do hope we've convinced you that adding an SEM consultant to MSK teams can really add value. And also, just to highlight the importance of delivering exercise medicine in every consultation, but particularly in musculoskeletal consultations. Thank you so much for listening. If there's anything else we can answer, please go ahead.
So we've had a couple of questions. We don't have much longer to go, and as I say, we for those who are putting their names to their questions, we should be able to answer them by email afterwards. But we've had a couple of questions for Mike about setting up the service that are quite interesting. So we are doing something similar in Northern Ireland at the minute, although our remit is limited to primary care. How did you get buy-in from secondary care colleagues? And then another question, which was, what were the biggest barriers to setting up your service? And how did you overcome them?
I think the short answer to both is with difficulty. I think the problem is from the secondary care colleagues, there is a natural suspicion of somebody trying to steal their territory, if you like. And certainly the younger secondary care consultants tend to have a better understanding than some of the older ones, let's say. I think it's very important if you worked in the secondary care service that you're trying to set up with, that certainly helps. So you're just building up. They understand you, you understand them, and there's a degree of trust both ways. I think the major problem with the NHS, and I'm aware that commissioners are listening to this, is that what I found is that in order to set up a new service, you have to demonstrate that you are either going to save money or generate money, or ideally both. What I was able to do by doing the audit for a year was able to demonstrate both of those things, because trying to set up a new service in a hospital is so difficult. I think we all can appreciate that if we were starting the NHS from scratch today, then MSK and exercise medicine would be at the top of the tree, because we're into the prevention side of medicine now than anything else. But because that doesn't exist, it's trying to take money from other specialities sometimes, so orthopaedics, rheumatology, pain services, in order to set up a new bespoke service. And it's whether you take that money from secondary care or whether primary care CCGs fund it and commission it, and that is the difficulty. And there are so many ways to do it. And I think if you talk to other people that have set it up, they've come up with all sorts of unique ways. But one thing I found very disappointing, actually, and one thing I'd like to see is as Natasha showed in one of her slides how many trusts and services now have an MSK service, and yet we've yet to have a national MSK conference where we actually share ideas about common practice and common financing. I think that will answer your question in more detail.
Thank you very much. And I think we have pretty much come to the end of our time now. Thank you to everyone who has attended, and thank you particularly to those who've asked questions. And as I say, those of you who've put names to your questions and we haven't managed to get round to them, we will answer them afterwards. You will all get a link to the recording of this webinar, so if you want to watch again or refer other people to it, you will be able to do that. And huge thanks to Natasha and Mike for presenting this webinar. Thank you all very much.
Thank you.
Thank you.